So, what am I going to be talking about for the next at least 6 weeks? I'm going to be talking about TRT, teaching the basics of how to assess, prescribe, and manage medical TRT. This first lecture is just some basic overview stuff and important background information. Very little about testosterone, but it is very important background information and stuff you need to understand my approach to things. So what is this course? This course is practical. The things that you learn in this course, you won't learn anywhere else at the present moment. And that last part is a little bit scary for me because when what you believe is different from what the majority of others in your profession believe, that's a sign that you need to be cautious, extremely cautious. So the course is very heavily grounded in my interpretation of the research, but that's the key part, my interpretation. So it's always subject to change. A lot of courses for healthcare providers, CME courses that teach HRT, their advertising purports to tell you the truth, the hidden truth. And that's nonsense. Medical research and medicine in particular has little to do with science and nothing to do with truth, actually. Medicine is a field that uses imperfect evidence and uses it to come up with tools that work often enough to be useful to solve problems. So it's a pragmatic field. It's not a field that is, strictly speaking, a truth-seeking field. And it's not a scientific field, okay? We're concerned with utility. Does this tool, and we're going to be talking about the tool called testosterone, is that likely to work for this specific patient? We aren't concerned with uncovering truths that have been hidden by the evil endocrinologists that are hiding the testosterone and trying to restrict people from using it so that we can all, be feminized slaves. That's a conspiracy that a lot of people believe, or some variation thereof. Okay? And that brings me to my second point. The course is not designed to endorse delusions, however popular they may be. Okay? Conspiracies are very popular. Many people today believe doctors hide things from them and that we push drugs on people for personal profit, which is nonsense, which is counterfactual. In extreme cases, conspiracies like this are persecutory delusions. And when patients are delusional, that can be a problem, but it's even more so a problem when physicians and so-called teachers buy into and endorse delusions. So that's what many people who teach HRT courses do. So you're not going to get that from me, okay? You are not going to get, also, I'm not going to throw members of my profession under the bus. So if you came to learn how dumb and wrong and pig-headed endocrinologists and urologists and primary care doctors are, you're going to be disappointed because I'm not doing that. That's also stupid. Okay, endocrinologists are very talented, smart physicians who are highly necessary. So I would be wary of anybody that teaches HRT courses, so-called, that tells you, modern medicine or modern endocrinologists, they just don't care about you. They're just out for profit and all this other nonsense. Okay. Point number 3, related to point number 2, is the concept of hiding treatments is nonsensical on its face because it presupposes that medicine actually has the ability to obtain truth. And it doesn't, because medicine doesn't have any unique possession of the truth. That's not the purpose of medicine. So since it has no ability to find and possess the truth, how do you hide something that you don't even have possession of? You can't. Okay? Forgive me for this fly. So with that out of the way, what is medicine? Medicine's an applied science. Okay, they call things like sociology and clinical psychology and even things like geology and astronomy applied sciences. But that's a misleading term, because actually medicine is much closer to a pseudoscience than it is an actual science, a hard science, much like clinical psychology is closer to a pseudoscience than an actual science. But saying something isn't science doesn't mean that it's not useful, because both are very useful fields. But medicine in particular, and you'll see this when we read the testosterone research, has several important problems that hard sciences do not have. So what are those problems? The first problem is medical research can't adequately control for complexity, at least not in the way that real scientific research requires. Okay. In fact, most hypotheses in medicine can't even be tested for ethical reasons. In physics, for example, we can control variables so tightly and reproducibly that experiments can be replicated literally thousands of times, down to absolute, like, precise decimals. Okay. And the confluence of experimental results in a field like physics can be used to generate universal laws, mathematical laws. E equals mc squared. Force equals mass times acceleration. This is the goal of scientific research. Okay. You can use it to construct universal laws that apply pretty much everywhere. You can never do that with research in psychology or medicine. You can't even test most hypotheses in medicine. We can't give people 1,000 milligrams of testosterone daily just to see what it does. Okay, it was not ethically possible to do that. Not having evidence of harm should not be conflated with there being no harm. Okay, in other words, absence of evidence not the same as evidence of absence. I don't know why today that gets, well, I do know why that gets confused frequently, but that's an important thing to remember as we go through the course, because you're going to find there are surprising gaps in the testosterone research that are very hard to close. So that you have to remember that absence of evidence is not evidence of absence. In medicine, we're always dealing with confounding variables, and we can't test hypotheses in a reductionistic and highly controlled fashion. So we get incomplete pictures. Not only do we get incomplete pictures, we get experiments that oftentimes can't even be replicated. That's called the replication crisis. The replication crisis is where many experiments, when performed with similar or even the same subjects under similar or even very similar conditions, can never be quite the same conditions. And if you want to be, really strict about it, you can never really, even if you're using the same people, they're not really the same people. I'll talk about that in a second. Okay. But we have a replication crisis in the applied sciences. This is in clinical psychology. This is in medicine too. In medical research, something like 1/3 of clinical trials can't be replicated on repeat experimentation, up to 1/3. And that includes landmark clinical trials. So think about that. 1/3 of trials that we use to format guidelines and to format the way that we educate medical students and residents, 1/3 of those studies are never replicated. In preclinical cancer research, for example, 2/3 of studies can't be replicated, especially if they're positive effects. So cases that can be replicated in cancer research, preclinical cancer research, even when repeat experiments can replicate a positive effect, 90% of the time the effect is significantly lower than in the original experiment. Keep that in mind as we go through the research, the testosterone research. Paradigms. What are paradigms? Paradigms are a set of mostly unexamined beliefs that lead to a specific prescription for how you should practice. So in other words, paradigms help us form what's called the standard of care. Paradigms are a problem in medical research, and especially testosterone research. We'll just discuss that in future lectures. But it's very important to keep in mind that research, and especially how it's interpreted, is always within the context of the culture and the paradigm that we're in right now. So what is the overall or the large paradigm in allopathic medicine right now? It's this idea of evidence-based medicine. This idea that we have to have randomized controlled trials that guide or direct our practices. You could even say when it comes to testosterone, there's a sub-paradigm, or at least you could say that the way that we prescribe testosterone is a product of the evidence-based paradigm. Okay? Just because something is so-called evidence-based, again, whatever that means, does not mean that it's true. And it definitely doesn't mean that it's useful. Okay, I just talked about how medicine is about utility. We're not car mechanics. We don't deal with inanimate objects. Okay, we have to have solutions and tools that actually are useful in the real world, that actually solve problems. That's not really science per se. When it comes to testosterone and operating outside the paradigm, when you do that, you are considered to be practicing in a non-evidence-based manner, which people conflate with practicing in a dangerous manner. And it's not. Okay. Evidence, particular medical research, the conclusions are always open to interpretation and reinterpretation. So just because most doctors believe one thing is true does not make it true. There are all kinds of examples in history. The one that's the oldest one, at least on this continent, that most people understand is bloodletting. Bloodletting used to be a standard practice. People would get sick, we drain their blood. We drain their humors. Well, we know that was an utterly absurd and harmful thing to do now, the benefit of hindsight. But if you could go back 300 years and tell a physician at the time, bloodletting is really harmful, you shouldn't do that, they laugh at you. They think you're an idiot. Or they become confrontational. Call you whatever their term was for a quack at the time, because that's what everybody did. Okay. But again, just because everybody believes it, even if it's the majority of so-called experts, doesn't make it true. And more importantly, doesn't make it useful. Okay. Paradigms aren't based on truth, and they aren't based on science either. I would argue that in medicine, paradigms are largely based on consensus. Evidence-based medicine should be renamed consensus-based medicine. And consensus-based medicine is obviously open to political influence. Last point on why medicine can't be a science and will never be a science. And this is far and away the most important point. This is far and away the most important point. Medicine deals with human beings. This is something that is frequently not understood. Because I've taught medical students, I've taught residents, I've taught lay people. Whenever you're dealing with human beings, you're not dealing with planets. You're not dealing with atoms. You're not dealing with even inanimate objects. You're dealing with dynamic, ever-changing creatures. They change in response to their environment. They change in response to shifting cultural norms. They change even in response to being observed. There's a phenomenon in human research that applies to both medical research and clinical psychology, where even the act of observing human subjects changes their behavior. That's called the Hawthorne effect. It's somewhat analogous to what we see in quantum mechanics and physics, called the Heisenberg uncertainty principle, where the mere act of observation changes the outcome of the experiment, I guess the way I would explain it. So if it's the case that humans change constantly due to 1,000 different factors, then it's no wonder why we have a replication crisis, and why even experiments with the same subjects, it's hard to replicate them. Now, what can you get from medical research? You can get not truth, okay? You cannot get universally applicable laws. All right, so anyone who says, oh, there's an experiment saying the ideal estradiol to testosterone ratio is XYZ, we're going to talk about that in great detail. This is counterfactual nonsense. There's absolutely no truth to deterministic statements like that. You don't get that from medical research. The best you get is statistical likelihoods. You get this kind of population experiences this percentage of improvement in this specific disease under these specific circumstances in this specific study, which may or may not be repeatable at another time and place. So you will never get universally applicable rules or laws in medical research. Never. So that means, to me, and to countless people throughout history until the modern era, that medicine is much, much more of an art form than anything scientific. At the end of the day, medicine is about dealing with people and their ever-changing contexts. The current generation of doctors, and this is, I would say this is true not just in the United States, but around the world. What I've observed is and what I've read and in talking to other people, particularly professors in medical schools or people who teach residents, or in the United Kingdom and in Europe, they call residents registrars. The current generation, they don't have they're not well read. I mean, with some exception, they're not well read. They don't understand philosophy. They don't understand literature. And the consequence of that is they're not good at critically thinking. Critical thinking skills are very important, obviously, when it comes to practicing medicine. And this is the reason why point of care tools, which we have in the hospital, we have in the clinic, Hippocrates, Up to Date, all these AI chatbots, these tools actually haven't really improved the problem of diagnostic error. Okay, diagnosis is a prime example of the extreme limitations of things like artificial intelligence. when applied to medicine. Diagnostic error is still incredibly common, despite all the technology that we have. 1 in 16 or 18 patients in the emergency room in this country is misdiagnosed. 1 in 18. Okay, that doesn't seem that high, but it is very high because a lot of these misdiagnoses are consequential. They lead to morbidity, they lead to delayed care, they lead to, in some cases, even death. So what we do is extremely high stakes. And unfortunately for hospital administrators, aka narcissists and psychopaths, which is, the overwhelming research shows that hospital CEOs, for example, have a up to 7 times higher rate of cluster B personality disorders. These people want to replace doctors with low paid, minimally educated individuals using Chat GPT. Essentially, that's what they want to do. And the motivation is financial. But why is it the case that things like Chat GPT or any kind of, they call them language learning models, why can they never be expected to fix things like diagnostic error? The reason is because diagnostic error is overwhelmingly due to errors in cognitive reasoning. Misdiagnosis oftentimes is a result of errors in critical thinking. Contrary to popular belief, AI doesn't fix that. In fact, not only does AI not fix that, I think you can make a very, very good case that actually AI will make that worse, because technology can't be used as a substitute for abductive reasoning. Abductive reasoning is a large way through which doctors arrive at a diagnosis. We come to decisions based on a combination of abductive reasoning and probabilistic reasoning, or Bayesian reasoning. Okay. And AI definitely can't do abductive reasoning, which is why it does not help with diagnosis nearly as much as people think. AI can engage in something that approximates probabilistic reasoning, but only inside very narrow domains. Every week, I get 2 or 3, sometimes 4 emails or messages on 1 or more of my social media accounts from someone that's opening an HRT clinic. HRT is super popular. Everybody wants to do it because it's a big money-making thing. And they have this false impression that AI is going to make everything easier. They can just hire someone fresh out of NP school, give them a $200 a month advanced Chat GPT subscription or whatever it's called, plug in some protocols, and that'll be sufficient. Now all of a sudden they'll be able to be safe because what you can upload the labs, you can upload even imaging if you have it. You can upload even like inventories where patients rate their symptoms quantitatively. And the chatbot will spit out a bunch of recommendations, and you can refine it to, follow certain protocols and things. AI is not going to replace doctors anytime soon. We'll come back to this in a minute, okay? Back to medicine. Medicine is about utility. It's not about truth seeking. It's not about science. It uses scientific tools, but it's not, strictly speaking, science. But medicine is useful. Okay, medicine can solve people's problems, and research can help us solve people's problems. But it's not a truth-seeking endeavor. If you want to find truth, then go into physics or mathematics. Medicine is not a truth-seeking endeavor. We use incomplete evidence to help us with probabilistic reasoning to solve people's problems. Why do TRT clinics exist? Everybody wants to be on testosterone. Even a lot of women want to be on testosterone these days. The simplest surface level answer is because testosterone is desired. People want it. patients want it. So they don't get it from mainstream medicine, and that opens the door to other clinics that can provide what people want. That's why a lot of you are here. Unfortunately, a great deal of experience, not just my own experience, but the combined experience of myself and other people in the field, is the vast majority of HRT clinics are dangerously run. They don't, unfortunately, know what they're doing in most cases. There are exceptions, obviously, but by and large, it's the Wild West. And that has economic implications too, because, for example, we know that something like 30 to 35% of patients that go to your standard brick and mortar, even the online may even be higher. About 30 to 35% of patients do not continue going to the clinic after a year. And many stop using testosterone completely. So TRT clinics, the way they operate right now, lose money, and in many cases. Money and patient retention come from achieving good outcomes. It does not come from achieving certain lab numbers. Okay? It does not come from blindly following algorithms, whether they're based on lab numbers or not. It's about solving problems. So if you can't solve problems, you can't run a viable clinic, and you are useless. Sorry to say. To patients, you are useless. Artificial intelligence. I already told you how there's a lot of people, particularly administrators and investors that I talk to, that think that AI is going to make it easier for inexperienced and undereducated providers to do what we do. One of the most pernicious and counterfactual predictions with AI is that inexperienced people become experts with the use of AI. You just plug stuff into ChatGPT and you get instructions on what to do. And for the investors, I think, okay, great. Now they can see more patients. Now they can bill more, and we can make more money. Is that really how it works? The answer is partly yes, but not in the way that you imagine. And it doesn't probably help the people that you think it will help. What AI does is it helps people, it helps experts become more efficient with their workflow. Like, it flags abnormal labs. It can help you with charting. It can help you with writing notes. It can even help with patient engagement. But it doesn't turn non-experts into experts. Okay, I would even say and argue, and many other people that are far more intelligent than me have argued, that in its current state, ChatGPT and other similar language models, large language models, are not significantly more useful than, for example, scrolling TikTok. Because what do you get when you get medical information on social media? You get information. You get unstructured information, which may or may not be true or logical in many cases. In most cases, it's not. In most cases, it isn't. But unstructured information is not knowledge. Okay, so I want to just repeat that because it's important. AI provides unstructured information. It does not provide knowledge. So right there, AI can never be used to close the gap between experts and non-experts. AI in its present state, I would say is even worse than social media in many ways, because the outputs that it produces are worded in a way that make it seem like structured knowledge. Okay. But it doesn't. But it makes it so it's easy to fool people who aren't experts into thinking that it does. Okay. AI, unfortunately, confabulates, or they call it hallucination. Hallucination is not really the correct term. What AI does is it confabulates. It makes shit up, to put it in very simple terms. If it doesn't know the answer to something and it's not able to arrive at an answer through simple pattern recognition, a lot of times it will completely make stuff up. Sometimes it will even, well, I don't even want to say sometimes, a lot of times it will even generate completely fictional references. The other problem with AI is AI chatbots don't have empathy. Emotional empathy is an extremely important component of medical practice. And you can't be a good doctor without empathy. Because again, like I said, medicine is about utility. It's about dealing with people and their dynamic foibles and what I call context. It's another way for saying people are fickle and changing. Okay, so that's where empathy comes in. And chatbots will not and will never, and AI, even if it achieves general intelligence, will never have empathy. So because it doesn't have emotional empathy, it's not really safe because it can never fully contextualize people's situations in the same way that a human can, for example. But again, what it does do is it lets experts who can do that automate or streamline tedium, charting, okay, certain engagement things, billing, whatever. It can do stuff like that very well. What it cannot do is replace an expert, empathetic physician with experience. And I don't think it will ever be able to do that. Non-experts, when they confront confabulation from chatbots, are much more likely to accept the outputs and to use it clinically with disastrous results, by the way. So in medicine, using large language models, I'd say is very dangerous in the hands of the wrong people. All right. In computer programming, for example, you have coders that are experts. You have coders that are more general, non-experts. What do we know from introducing various AI and AI-like tools to programming? Did it make the non-experts coders better? Well, I guess it depends on what your definition of better is. It made them more productive in the sense that they can produce more code, but they produce flawed code. So it doesn't actually produce beneficial outcomes in that same sense. But for the expert programmers, it makes them more productive. Hopefully that makes sense. The overall, and I don't think medicine will be any different. Okay. I think medicine and AI in medicine will make those of us who are experts in our field much, much more efficient and much better at solving problems. But I think it will make non-experts much worse than they already are. And when it comes to TRT clinics, they're really bad. So I predict that there's a huge liability issue with the way that modern TRT clinics are structured. And I think many of these clinics will end up going bankrupt. Because the people like me, I already said 30-40% of patients at TRT clinics don't stay with the clinic after a year. And I don't run a TRT clinic, but I do prescribe testosterone quite a bit, obviously. These clinics cannot compete with people on my level. It's simply not possible. It doesn't matter how many large language models they give them. It's irrelevant. These people don't know what they're doing, And no amount of tools are going to change that. And there's several examples from both recent and past, distant history that I think support that assertion. So, long story short, if you think you're just going to open up an HRT clinic, hire a bunch of freshly graduated NPs and give them computer programs that are going to make it safe for them to see 8 to 10 patients an hour, that's a recipe increasingly for bankruptcy and lawsuits. That's my prediction. Okay? I think it's going to be a bloodbath. So hopefully this course will help people to advance their understanding of how to use the tool of medical testosterone. But again, please do not think that I am, even though I'm using medical research to support my positions, and I think my positions are grounded in the confluence of current research conclusions, this is not like you're here to learn the truth. You're here to learn the hidden truths of testosterone. Here's really all these endocrinologists. They're trying to keep testosterone secret and hidden from people so that people remain sick and that so we can get people hooked on big pharma. That's all nonsense. This is not about truth. And like I said, this is not even about science. This is about practicality, helping people. And ultimately what it's about is probabilities and risk-benefit analysis and improving people's lives. That's what patients care about. That's really the reason why my clinic has a 97% retention rate compared to 65%, 60%. Because I get good outcomes consistently because I'm an expert, I know what I'm doing, and I know how to contextualize people's problems. TRT clinics do not know how to do that by and large. TRT clinics know how to use algorithms to have a revolving door that people go in and come out of every 5 minutes. That's not safe. That's not ethical. And ultimately, since administrators and investors don't give a shit about that, it's also not profitable. And increasingly, it will not work. It will not work long term. So hopefully by taking this course, you will be able to advance your understanding, which is another way of saying you'll be able to help people. You'll be able to actually solve problems in a safe and effective manner. And that will result in greater long-term success. Okay, so that's lecture number 1. Lectures 2 through 6, there may be up to 8, depends on if I add, more stuff. Like we may add in some stuff like testosterone for women. We may add some discussion on the care of patients on synthetic androgens, non-medically by themselves. I don't teach people how to prescribe drugs that are not considered to be for medical purposes, but it's a fact that steroids are very popular and men want to use them. And, so you need to know how to take care of those guys. And so I will add a lecture on that if there's enough interest for that. So we'll query people as we get closer to week 6. If you heard this lecture, which is the free lecture, the rest of the lectures will be on Patreon, C Bronson, patreon.com/C Bronson, for healthcare provider level subscribers and above, which it's $30 a month right now. Next month, it will be double the price. So you might want to get in now. And we'll be back next Thursday. Next lecture, we'll actually discuss hormones.